go. I go. Yes. I go, I may is a West African call and response. We use it in our community to bring our attention. And so as part of my cultural tradition, is to have call and response to make sure you're being heard. So thank you for participating. So I'm excited to facilitate this panel discussion by these amazing women, might I say, women, that I've gotten to know, who have some very interesting, and I would say not just unique, but innovative care services that we're going to hear about. And so I think that there's going to be an introduction that's going to happen. Today we're going to talk from leaders across the country about the unique care services offered by their cooperatives, from end-of-life care to errand support to caregiver outsourcing. Cooperatives new and old will gain new inspiration for diversifying their businesses and increasing their revenue stream. So we're going to start by having each panelist introduce themselves and their cooperative name, location, and how many years they've been in business, and any other relevant high-level details. Before then, I think there was an introduction.
All right, so I would like to introduce our moderator or facilitator, Asada Richards, the founding director of Sankofa Research Institute, a nonprofit with a mission to create knowledge to build community through community-based participatory research. She was elected as the founding board president of Community Care Cooperative, Houston's first home care agency owned by caregivers. So welcome Asada and to our panelists.
So now we're going to take a moment again and let each panelist introduce themselves. And we're going to start with Ms. Wagner.
Hi, I'm Brittany Wagner, Human Resource Coordinator for Cooperative Care in Watoma, Wisconsin. Our cooperative has been open and running and serving clients since June of 2001, working with county program clients. Since then, we have now branched out to 6 counties in our area and serve a variety of clients from publicly funded to private pay to also VA.
I'm Kathy Rivas. I'm from Heartstone Home Care Cooperative in Anacortes, Washington, so just about as far as you can get from here. It's not Peru. We opened our doors in September of 2021, kind of in the middle of COVID. But for us, nothing changed. And so we're doing everything from companionship care to last breath care. And we're empowering our team to just do the great things and to be integrated into our community, helping as many people as we can.
I'm Susie Rosette. I'm Executive Director of Cardinal Comfort Care, and we are located in the northeastern part of Minnesota. So we're called the Arrowhead region. And we're right on the beautiful shores of Lake Superior, and it's a beautiful place to live and work. But more importantly than that, we have some fantastic caregivers in our area and with our cooperative that serve everything from homemaking to end-of-life care. And I'm very grateful to be here.
Thank you.
St. Cloud, Minnesota. And we do not have a license yet, so we're not actually up and running. We're the babies, but we're getting there. The team is currently employed by an LLC providing the service that we do, that will, the team will follow to the co-op, and the people we serve will follow to the co-op. So we are just excited, waiting for that piece of paper.
Wonderful. Sounds like a very good team. And so now we're going to let each panelist talk about their unique, I say innovative care services. We're going to ask you to say, what is that service? And in the case of Minnesota Lifestyle Solutions and the IH program, the explanation of the goals of the program and the training. What is the demand? Staying with the business ideas, or why is this a revenue positive? How much do you charge for the services? Relevant for comfort and sharing, and just to give people an understanding of how they can monetize this work. And then how did the services come to be? Each of you have a very unique story, and it really comes from your personal lived experiences, and I think it'll be helpful for people to know that innovation comes from our lived experiences. And then how did your co-op go about deciding? Yesterday we talked about values. Did you use any values, personal or business values and principles of the co-op to get that work done? And so let's just hear about these wonderful things, and we'll start with Diane.
Oh, I'm gonna start with Brittany. Okay. Minnesota Lifestyles will be providing, we currently are providing. We currently are providing with the other LLC that we're working with, but we will be providing what's called in-home supports with training intensive services under what the state of Minnesota calls 245D licensing. And as far as innovation, we're also expanding into waivered services, which is not required for license, but then we can initiate and start getting the revenue from those services as well. So in-home supports with training is the team is training the individuals that we serve to increase their independence in the community and to achieve the goals that they've identified for themselves. That can be anything and everything that it takes for them to be able to live in the community and not end up in foster care or a nursing home or anything like that. So it's really exciting, it's very challenging work, but the team is awesome at it. It's very person-centered, so the individuals set their goals. What do they want to accomplish? We don't tell them what to do. We support them and we teach them. So household management, everything from how to structure their home, keep it organized, how to file those papers, how to complete the applications to get food support or get their medical insurance, everything and anything. We help them find doctors if they are in need of that. We help teach them how to arrange transportation if that's available. If not, we provide that transportation to the doctor. We support them at the clinic if that's what they need and choose to have. Because we've got individuals with like a TBI and they don't remember what the doctor said. We'll sit there, we'll take notes, and then we can refer back to that. Anything with the household. We don't do any hands-on services. As one team member said, hearts in, hands off. The only thing we can do is offer an elbow for them to hang on to us if it's icy or uneven sidewalks or anything that you're walking on. So it's nothing at all like personal care. We just need to support them where they're at. And so the basic goals that people choose is the household management. How to keep a household organized and running and everything that's involved. Processing mail, paying bills, developing strategies on how to pay those bills and remember to do it on time. We work with them whatever works for the individual that we serve. The other one is community integration and socialization. Some people just isolate and they just don't get out, and we just help them find resources in their community that they're interested in and connect with those individuals. Whether that's a support group or it's, they love painting and there's an art class, whatever it is, we help them do that. We help them find resources in their community to meet their needs, whether that's food support, whatever they need. The other is, household. Transportation is a big one, supporting them in that, maintaining their household. What's the third one?
Community integration.
Thank you. Community integration. Community integration and household and,
Well, let me help you.
thank you.
Let me ask you this. What is the demand and how much do you charge and who's paying you?
Okay, so the state pays because we are a waivered service through the Department of Human Services. So they set the rate. And each individual has they complete what's called a mid-choice assessment, a Minnesota assessment. First one is 750-some questions, to help the person identify exactly what they need. So all that is entered into a computer logarithm, and that picks out how many hours of service they are authorized whether it is PCA or housekeeping or our service, IHS intensive services, it says, you know, this person is authorized 3 hours a week, or 15 hours a week, or 40 hours a week, whatever that logarithm identifies that they need. From there, that goes to a county case manager who writes what's called a CSSP, Community Support Plan. And they help the person narrow things down, identify what kind of goals do you want to work on. That's when the case manager calls me and said, do you have staff that are able to support this person? And it's like, of course we can. So then I go in there and meet them, and we write an addendum to that support plan, identifying what the person really wants to work on. Just because the county says you should work on household organization, you should work on finding stable housing, you should work on that, doesn't mean that's what the person wants to work on. And those goals change. We review those goals almost every single visit, we work on them, we have a plan, we document that we worked on them. And if they change their mind, it's like, you know what, I don't want to work on that anymore. I just want to put that goal on hold. Yeah, I said I wanted to get my driver's license, but I'm just not ready right now. Let's do something else. We switch gears and we work on what they want to, because we're very, very person-centered. That's critical to us. So that's what we do.
And then the nuts and bolts is how much do you get reimbursed? And then how much does the caregiver, we're not calling it a caregiver, the person that is providing these services get paid hourly?
Okay. So the rate varies. Right now we're in 5 counties. The rate varies a little bit by county because it doesn't pay quite as well. And the rate did just go up on January 1st. So we get reimbursed anywhere from $11.01 to $13.53 per 15-minute unit. So 13.53, we're making it $54 an hour. We are going to start paying our workers at 22, and they will also have PTO and then Minnesota's safe and sick time available. And we're working on adding benefits too already before we even started. So that's where we're at.
Yeah, and our final question is, how did this come about? And what decision-making did you go through as a cooperative to launch this new service?
So we've been doing this service. Minnesota took the federal program, the Home and Community-Based Services, and every state kind of did their own little tweak on it, but that's what Minnesota did. Originally it was called 245A, and yeah, I was providing the service back then. I've been in this field for a while. Then the licensing came down and they changed to 245D with all these rules and regulations and things that you have to do. And now it's called Waiver to Reimagine. They just keep tweaking things. It used to be called Independent Living Skills Specialists, and now we're In-Home Support Specialists. They just changed the name. There was not a whole lot of that because it is who we are. So the demand in the community has been there, and Minnesota was innovative in identifying that and setting up this waivered service to do it. And I just fell into the opportunity to do that.
And brought that opportunity to the business.
To the business, yes, because this is an amazing team of people that I work with, and actually they're the ones with the motivation behind even starting the co-op. I've worked with companies, except they're a supervisor, but we're a team. The case managers would say, Diane, do I really have to talk to your boss, or can I just talk to you? And it's like, yeah, you can just talk to me, because it was just a challenging company that we were employed by. And it's the county case manager who said, Diane, why don't you just do this on your own? The team got wind of that and said, we can do this? It's like, of course we can do this, let's just do it. And being me, I had to reach out, because I know what I don't know, and I'm willing to ask people about it.
Yes.
So we reached out to LLCs. I did into the area and kind of did an interview thing. You know, it's like, how did you get started? How did you decide? How did you, what did you do? And every single LLC said, Diane, you want to line your own pocket, don't you? And it did not sit well with me. It's like, well, if I'm doing this all by myself, sure, I'll take the money, but it's not me. It is the team. So one of the team members came up with the concept of a co-op. Said, let's do this. So we actually filed for our cooperative, State of Minnesota Secretary of State, February 18th of 22. And then we filed for our 245D license on May 14th of 22. We are not licensed yet. We are still waiting. Yeah, it's coming up on 2 years. So that's why we're starting with services that don't require the license. So yeah, it's intense.
Thank you, and I just want to note, I still want to describe this as a conversion, because you were an entrepreneur, you were maybe going to do it on your own, and then you were educated and engaged by a cooperator to say, hey, there's another way to do this work. one that benefits you, but also benefits others. And that's just the power of being able to educate and engage people around our model and our work. So thank you, Diane. Next, we're gonna turn to Susie, and I started with you, Diane, because I want the notes to be fresh. We're gonna turn to Susie and ask the same set of questions, Susie. What is the service? What is the demand? How much do you charge? And how does this come to be? And what decision-making has to happen in your co-op to do this unique service offering?
Okay, so I was asked to speak on hospice care and how that came about in our cooperative. And it actually is organic for us because Dave and I did personal care hospice for many years. And we basically converted that business. What happened is we saw this huge gap between people who had money that could die well and people who didn't have money and were dying very poorly. And that was just breaking my heart. So I applied for a 245D license through the state of Minnesota so that we could start serving Medicaid patients. And that would help me do, work that I wanted to do. And in that time, we were offered an opportunity to start a cooperative in the state of Minnesota with a grant that was put out where they wanted the care workers to start their own cooperative. So we really got a boost in the arm when we got hooked up with MCCD, and they are, a cooperative developer. And they have really, really worked hard with us to create this cooperative. The hardest thing is to, because I've been an entrepreneur all my life, it's kind of easy for me to think in terms of, I'm an owner. And the hardest thing is getting the cooperative members to think, hey, I actually own this company. And, start moving in that direction, with their hat. But at any rate, so it organically happened where, we specialize in hospice. And it is a very rewarding, incredible opportunity to learn about yourself. People are so gracious, and we've just had just wonderful clients over the years. And I've learned a few things. And one of the things that I learned is when you say hospice and people are signed up for hospice, what happens is the family thinks that, okay, hospice is here. I don't have to do anything anymore. And the reality is that Medicare and Medicaid pay for a hospice service, okay? That's a totally separate service paid for by Medicaid. And what they get is a nurse that comes in once, maybe twice a week for an hour to check on them and, just see how they're doing, about an hour. And then they get what we call a home health aide, which usually is the bath lady, we call them, or gentleman. And they come in and give the person a nice bed bath or shower or what have you. But then the rest is on the family. And they're kind of shocked with that. And they're saying, oh, we need way more help than this. So that's where we come in. And when I say hospice care, we're basically an ancillary to that hospital team. So if I can describe it in terms of, can you hold this for me? I always like to tell this story because it really depicts what we do. If you don't, I love science and nature and things like that. And one of the things that happens when a dolphin gives birth is that they get very weak, like a human, right? We need help, we need midwives, we need people around us to kind of help us through that process. And what happens is as they're going through that birthing process, they get weaker and they can't get up to the surface to get air. So what happens is other dolphins come up and they push her up so that she can get some air. And then when the baby comes out, the same thing. Another dolphin comes up and helps that baby get air while the mom is recovering. And it is just, that's how I see us in this field. We're there, we're dolphins. And that's how I see us in position. So it's always the hospice team is up here. You know, they have the doctors, the nurses, and all that good stuff that they pay heavy money for, licensing. And then we get to come up and we get to be there the whole time with them if that's what the family wants. As, you know, a couple of the questions that were in the packet were, you know, how do I schedule hospice people around the other caregiving hours too? And basically it's the same. We provide them whatever they need, whatever the family thinks is important to that person. And a lot of times, and I think this needs to be said, a lot of times it's just your presence. So when you're sitting there and they're reading a book, maybe you're reading a book, don't underestimate the power of your energy in that room for that person, and that's work. That's work. That's hard work. So I just wanted to put that out there because that can happen a lot. And what happens is people, they move in and out of phases of the dying process, and when they come to the place where they're in an active dying phase, that requires a vigil. And in vigil care, you're there, and this is what I suggest to families is beneficial. You're there with that person the whole time until they die. So you can hand the baton off to another caregiver if that's what we need to do. But we are present and there at the time of death often. I have been seeing, and it's been really pressing on me lately, but I have been seeing a trend. And the trend is families don't wanna be in that room. Families don't, you know, they can't emotionally handle it, you know, and I'm not making a judgment. All I'm saying is this is a trend. We're not teaching our young people about death and dying. We're not teaching people about how this process works and how beautiful it can be, and how much you can learn, not only about that person, but yourself in that whole process. And each time you go through it, you just get more pumped up. I have stories, get a hold of me. I have stories that would just blow your mind. And nobody in this room or otherwise could tell me there's not a place outside of here on this earth. So we're all going to a beautiful heaven, or wherever you want to call it. And it's pretty amazing to see people come to that place. So,
And Susie, can I just ask you, who pays for the service?
So private pay will pay for the service. Waivered services through the state will also pay for that. So there's a combination, and the charge or the rates really depend upon the cares that you have to do. Some people have, you know, bed sores or, you know, really, you know, tough things going on. Other people maybe don't. You know, they're 97, they never took a pill in their life, and they're just, you know, sliding on through, you know, so, yeah.
And I think you told us that this came out of your own passion, and so, again, you're solving a problem based on your lived experience.
Yeah.
But how did the co-op talk about doing this service, and what was those discussions like? Because it is, you know, it's a demanding, emotional service.
Yeah.
So how did y'all come to the decision to incorporate this in your work?
Well, I think it's always been organically there. I don't know that we as Cooperative, like, have ever sat down and said, you know, we're doing this hospital. It just kind of always was there. But there is one thing that I really work hard at as being the administrator, is if anybody has, and you guys can share your experience too, but if anybody has anything that they need, any emotional need or whatever, I literally stop everything I'm doing and I'm zoned right in, and I'm like, okay, what do we need to do? How can I help you? And I think that really brings personality to it, and I would imagine we'd continue to, serve our members that way, because they're number one. And, yeah, did that answer your question?
That did. Thank you. And we're gonna turn now, to Kathy. Thank you, Kathy. And Kathy is going to, tell us about her innovative service, and again, what is the service, what is the demand, who pays for it, but the most important piece, I think, is how does it connect to your lived experiences and the uniqueness of why this was important for your co-op?
So I'm going to start with how we came to provide nursing pool or out staffing. In the state of Washington, you're required to get a home care license. And everything I'm going to tell you is about Washington State, and I'm not sure how it applies to other states because I can only speak from my experience. So we have a home care license, and we wanted to be able to provide temporary staffing to facilities, to assisted living, independent living, skilled nursing, boarding homes, whatever that facility situation might be. And the reason that I came to that was somebody asked me at one point before we became a co-op, does the company, the franchise company that you're working for, provide those services? And that corporate pocket that I worked in said, no, we don't do that, that's too much work. But facilities need caregivers too, they need staff. Those people living in those situations need staff, and it's too much work to do that. Okay, so when we founded the co-op, there was 5 of us. Well, it started 2 of us. And then there was a few extra folks that came with us from the company that we worked in before. And we were looking for revenue streams because clients, nobody knew who we were. They didn't know what we did. So we applied for this nursing license, nursing pool license through our state. Paid $126 to be able to go into a facility and say, hey, I have staff. You need staff? I can offer you staff because I don't have clients to get them money. And so we devised a service agreement that said, if you need us, $50 an hour for this caregiver and this caregiver and this caregiver, and you can use them like your regular staff, abuse them not at all, because they're beholden to me. I'm the guy that says, I support them, I take care of them, so if they're doing something, I want to know what it is so that I can support them through that part. And the caregivers were on board, they wanted to make a living. And we set our rate at $50 an hour so that we could pay them time and a half if they wanted to work time and a half. And if they didn't, we said, I'm sorry, we don't have anybody available today. But I approach it with such a openness. I always feel like if the business is out there and available, we should be out there and available. I respect my team enough that when they're not available, they're not available. And at the core of our business is our team, always. So does that kind of answer your
That
question?
does. I guess just to further the question, what is your mix now between services to facilities and services to individuals? Have you
You mean like
ratio?
doing nursing pool? We don't do any at all now.
Okay.
We started and we did a couple of contracts, and I found that big corporations do temporary staffing. There are big companies that do it, and they charge really crazy things, so I don't market it. But I stepped into marketing our community instead of 2 facility communities. So it's a little bit different. I think it's a great revenue stream. And the reason that I think it's great is because I can take one person in a full-time position, and once I've met all my overhead costs, that one full-time position nets us $52,000, give or take, in profit. So, would I promote it again? Absolutely I would. I think it's great if you have the staff to do it, and a way to market it, and you don't have other things going on. I think it's a great revenue stream. I'm always looking for ways to bring money to our co-op and to get us integrated into our community more. Now we have a big name and we have a huge reputation in our community, and it's not something that I feel like we need to continue to do, but it's always available if we want to do it because I maintain our license for it.
And this was before you had the home care revenue coming. So this was a solution to revenue and maintaining a staff so that when you had those in-home clients, you would have a staff ready.
And my thought in the beginning was, this is a great foundational way to have money coming into our business. And we thought it out, and at one point we thought if we could just get everybody working, doing nursing pool, and they wanted to do it, we could be $1 million in revenues. So it's a great thought, it's a great plan. If you market it the way that I should have done it in the beginning, I think it would have been amazing. But there was 5 of us. I mean, entirely, somebody's got to run the office, and we all
did a great job.
We were all billable back then. Thank you.
You're still alive to tell the story. I think this is amazing. We're just trying to survive another day. Now we're going to turn to Brittany to tell us about the services, the demand, how did it start, and how did you as a cooperative organization come to the decision?
So my cooperative has actually always ran errands. When we were in the county programs, the county would reimburse us for the miles that our caregivers ran. And then switching over to family care when things transitioned, family care no longer reimbursed for miles ran. And then over time, they did if it was any errands ran 20 miles round trip or more. But anything under that, they just kind of assumed that the rate that they reimbursed us for services just kind of covered round trip 20 miles. And even to this day, it still does.
So let me just remind everyone. So Brittany's cooperative unique service is errands, running errands for clients.
So we do run errands. Anything from prior to COVID, we ran errands for taking people to appointments, grocery shopping at the pharmacy, even just to kind of maybe pay their electrical or whatever the case may be. And it's kind of evolved from that. Over the years, there has been a larger demand for this service. And so we continue to increase that. And I'm so sorry.
You want to tell us what is the demand? You said it's increased. Did it increase before or after COVID? And then how much do you charge for the services?
So services are charged at that reimbursement, federal reimbursement of 70 or 67 cents. I'm a little nervous, you guys. I'm so sorry. You get So it is at that 67 cents reimbursement of federal rate. Private pay and our publicly funded are all charged at that rate. Private pay has a little more fluctuation as if they need us to run 100 miles round trip, they can do so. Our publicly funded is a little different as they need authorizations for miles. And that would just kind of depend on their needs and what they're looking for.
Okay, great. And then you said you've always done this. Why was this a natural service? What made it make sense to the co-op at the time? And then what changes did COVID bring about with the service?
So we live in a very rural area, and so not everybody had the capability of getting to the store themselves due to weather, road conditions, or whatever the case may have been. So we have just always kind of helped in that sense. And COVID has changed in the sense that our clients used to transport with our caregivers to go to locations and whatnot. And so when the pandemic came forth, to protect our clients and caregivers alike, from potential exposure, we eliminated that. So our caregivers are still able to go and run errands for clients, and even maybe follow them along. And like if they had another vehicle, they need to see the support at the location, they could follow along, but no longer transport with.
Yeah, and then, just Brittany to ask, do you do errand work that then turns into care service work, or is your errand work always connected to care services contracts you have, at least in the private pay?
So in the private pay, it really just depends on what the client is in need of.
And do you find it a recruitment mechanism into care services?
It is advertised that if, in our private area, that if somebody is in need of those services for errands, that we will provide, and then just kind of through contracts, let them know what that consists of as far as reimbursement, what they're allowed to do, and things of that sort.
Thank you. And so I just want to pull out, I think, and also tease, there's a lot of relationship here with the public sector, right? Looking at what the public sector is kind of spending, what is, where are some pools of money that you can tap into, which I think, I think when we think about this, we're all thinking about home care, at least in our part of the country, but thinking about what county services are being paid for, and figuring out what our co-ops can do to increase our revenue stream, just because, the care services reimbursement are so low for so many of us. So I just want to say, teasing out, saying every place is different, but maybe what we should be looking at is those requests for proposals, those buckets of money that are coming out in our region, and saying, can we do this thing? Do we have someone on staff that has experience doing this? What would it take for us to tap into these revenue streams? I just want to pull that out. Now I'm ready to go back to Diane to talk to us a little bit more in deep dive for a second into your services, Diane. And so what I want to follow up with you on is asking, so the IHS program covers a very broad range of services and supports. How do you prepare and support caregivers to be able to meet such a wide range of needs? Because it's a spectrum.
Training, and team support. That is so important. When I hire, I don't necessarily need to look at the experiences and the resources that the person knows. I need to see where their heart is and where they're coming from. You can train the rest of that stuff. If the person has their heart and soul in the right place, it all works.
Okay, let's repeat that. So, Stan is saying that people are trainable.
Yes.
If they have the right values and intentions, then she can train them on the delivery of service.
Right. So, that may
I'm sorry. Okay.
I've been asked, me and the team talked about this, it's like, what do I look for when I hire somebody? And what I try to do is offer a safe space for people to let me see who they really are. Because everybody's nervous, it's an interview, it's like an online hire, what's the lot. But if they have a safe space where I can see what their life is, and I can't identify what that is, I don't know if I'm gonna call it if they're caring or they're compassionate, I can't really identify it. But if there's a safe space and they can share who they really are, then it's a gut feeling, it's whatever, I can tell that their heart and soul's in the right place, and I can train the rest. You come in with somebody who has all the knowledge in the world and knows all the resources in the community and everything, but if they're not heart in the right place, it's not going to work, and I can never make it work. So that's how we hire, and then you train. The team trains, I train. DHS requires tons of training to do this job. And then the team support. Anytime the team needs anything, they call.
And is that one team, is that multiple teams, how do you structure the teams? Do you have team leads? And then also, I think an important question is, because this reminds me of community health workers, and the approach in Philadelphia has a lot of community health workers. But I think in our experience, Dean and I, and Tanisha, Dean and I work with our community health workers. Sometimes they think they know what's best, and we have to always say, wait a second, right? It's not you telling people what they need, it's you allowing people to decide what they need and you supporting those needs. Do you ever have those tensions in the work you're doing with people who may say, I really think this person needs this, but they only want this, and how do you negotiate that? And again, how do you structure your team?
We don't run into a lot of that because the team respects the people that we serve, and it is their life, not ours. We're there to support them to reach what they identify as their personal goals. And yeah, we see them making some bad choices. We do that with our kids too. It's like, you know. Maybe. So what we do is we try to problem solve, make lists, pros and cons, what are possible consequences, helping them make a good decision, but ultimately it's their decision. So that's how we do that. Structuring teams, right now there's only 7 of us. We're a pretty small team. We talked about this the other night, that as we grow, there will be team leads, because there's no way that I can supervise and mentor, 100 employees as we grow, because we're going to get there. So it's, the team leads would be, like coordinators or supervisors, whatever. But right now, the 7 of us, and plus the others that work with the LLC that are not part of the co-op yet, we have a text message, encrypted text message, so we're HIPAA compliant.
What service is that?
The tech, what?
Yeah, the text service.
Signal.
Signal, okay.
Yeah, we can do Teams too, just bought Teams, I gotta figure out how to use that one, but as long as they're HIPAA compliant, so that the team has the entire team support. You can send out a text message saying, this is what my person, I needs a resource for this, who has an idea what is there? They've just got a dozen responses. And then if there's a couple of team members providing services to one person served, then they work together to make sure the coordination of care is impeccable. So they said, this is what we worked on today, this is what they need, this is what they need to follow up on, just to make sure that nothing is dropped in the ball there.
Thank you. And I want to give a plug for sociocracy as you grow. I think you talked a little bit about this, but this came up in our prep call. Inherent in this is the loss of life. And how are you managing the support, the emotional, the grief of your caregivers? How are they managing that? And even just in scheduling, do they get a break between clients, when death has happened? And so is there any, services or any process that you go through with them to help them process the grief that they've witnessed? And I can just imagine that it also taps into everyone's own trauma and grief over loss. So how do you deal with that as an organization?
Well, I totally respect all of our cooperators. They're amazing people. I feel like there is a camaraderie between all of us, where they look to each other. I do have lots of reference books, especially, that can help people through. But I'm an open, anytime door kind of gal, so they can come and talk to me at any point, and I will stop everything and move them through. If it's triggering deeper trauma that needs more support, that's out of my scope of care, then I do have counseling resources and great people that, I can refer them to. But most of the time, I think if you do good training, and I can tell you, Diane is the training queen. If you need any training, she's got it. She helps with our training at our co-op too, so we kind of share her.
Cooperation among cooperative. I love it. All right, cooperation among cooperative.
Yeah, so I guess that's how we're dealing with it right now. What I would eventually love to have is a whole hospice grief training program that people go through. And there is a movement of death doulas that is coming up. A lot of people have heard of that. So we do have one person that has gone through half the course of death doulaing. And it would be nice to have a death doula on staff so that if people want that service, we can provide that through the cooperative.
And I just want to say, I think the death doula is great, but I think in our conversation, we talked about the death doulas focus on that individual per se, and I think what you're doing is focusing on the system, the unit, right, that's supporting the person in death. So I really love your innovation on it, because people who were left living, the person that's died and made that transition, but it's the people who are left living who need to be supported. And your work is really about supporting them.
The families, absolutely. So, you're gonna probably do more work with the families and their spouses or whoever is their main caregiver than you actually will do with the person that's going through the process, because that's a natural process. Their body's just gonna do it, and you can tell them what's going on with themselves if they want to, but it's more about educating the families. I really believe that. And that sets them up for the next event.
Thank you, because there are many in the life cycle. Brittany, let's talk a little bit more. And so, what are the errands that are most in demand? I think you talked a little bit about that. And how are errands built into a caregiver's schedule? And how do you maintain expectations and boundaries with clients? Because that's a hard one.
So the most in-demand errands that our caregivers run are shopping for groceries and to the pharmacy for med pickups.
And do people want to go? My grandmother always wanted to go to the grocery store. So I think this will be a hard thing for her. She wanted to go to several grocery stores to get the best sale price. But do a lot of seniors, how are people adjusting to not going to, because I know for older people going to the grocery store was a social event. And so has that changed at all? I just want to ask.
Absolutely. So prior to the pandemic, our clients usually needed to go, and it just kind of helped them have that independence. They could pick out their own groceries at the store. And then when the pandemic happened, it definitely did take a toll on the mental health of some of our elder clients, and it was really hard transition for them to do. Even now, we have a couple clients who will call and say, well, can I ride with? Like, why can't I? It's been, and we just still haven't lifted that policy for protection yet at this time. And then of course, the errands that our caregivers run for our clients is built into the client schedules, whatever hours they are authorized and with the week. They just know that a portion of that is going to be used for those local errands. And then as far as the expectations of it goes, we expect the client to have a list detailed if there's not an option, like if you want this, is there a second option of if they don't have it? And then making sure they have the funds available, whether it be cash, their debit card, or even a food share card. And if not, what's the backup plan? That way our caregiver's not at the register and we still owe $50 and there's not enough. And so that we want to make sure that's taken care of. And then on the other side, kind of an additive here, on the caregiver side, we expect our caregivers, when they arrive back to running these errands, to hand all receipts back over to the client with the form of payment, change, whatever the case may be.
And so, is there any grievances? Do you have any issues that happens on these errands where the client's expectations weren't met, and how do you resolve that?
There have been a couple of incidences like that where somebody wanted a Dr. Pepper, but they didn't have the actual brand, and so they had to get the knockoff brand.
That's me.
And so, in this one incident, it really angered the client, and why didn't I get a phone call? And so, we definitely do some additional training that comes into that, or we're, with our caregiver, hey, next time they don't have this, give us a call, we'll call the client and see if that's okay, or what another option may be.
Yeah, and I can imagine it's just a feeling of a loss of control of one more thing in your life. Like, I can't get there, and I didn't even get the Dr. Pepper. Yeah, just having enough compassion, I'm gonna be that person.
I heard they were getting rid of Dr. Pepper.
I'm gonna go for the Vernon. Anybody from Michigan know Vernon? Oh, the best. Okay. And so, moving to thank you, Brittany. And so we talked a little bit about this before, but how did the caregivers feel about the out-staffing roles? And I know in our pre-conversation, I thought, there could be some tensions because of course we are like saying, we're getting you out of those mean, bad facilities. We're gonna bring you into a new organization where you're gonna be treated well, right? So was there any issues? Because I think it's helpful for people to understand we love cooperation and we buy it, we drink the Kool-Aid, and other people are dealing with it differently. So were there any pushbacks for what it is that you are offering them in a cooperative? Going back into those institutions, so how did the caregivers feel about that? And what challenges have you faced from a scheduling capacity standpoint when you were doing the service?
Pushback. So I
Or
said,
resistance, or irritation?
I said that there is myself and my office partner, care manager, and we did billable hours in the very beginning. And when we started the nursing pool, we had 3 working care staff. And just miraculous, right? The 3 care staff are my 2 daughters and my partner's daughter.
Come on, let's talk about it. It's a family business. We said that yesterday. Yes, I love it. We don't talk enough about co-ops as family business. Let me just say that. Because we say tell our cousins, our nephews, go apply over there. I think they're hiring. Versus having a business that you can say, I work for this business. I'm referring you to this business because I'm an owner in this business. But, so
And
I
I
just
want
want
to
to
own with my kids.
That's
And
right.
I own with my husband, and I own with my best friend and her kid, and my sister-in-law. So family business is huge. That's a whole nother hour.
You can do this because you needed people that trusted, believed in you, saw your vision, and at the time it was your 3 family members.
Exactly. And so like I said, we didn't have any clients then. So it was how do we pay your rent? How do we pay your car payment, your car insurance, where I'm not paying it? Right? So let's go and talk to these facilities and see if we can lay some foundational hours for everybody to get a paycheck. Because when you're starting, that's the most important thing, is to get a paycheck.
And the co-op is supposed to meet our what need? Economic needs. So that's one of the things that we do.
And so we started out, and it was slow starting because it wasn't promoted correctly. I was not a marketer, I was a caregiver. 33 years at that point I had been caregiving. So I can wipe you, I can roll you, I can take you shopping, I can hold your hand through your last breath, I can do all that stuff. I was not a marketer. And the only benefit that I had behind me besides caregiving was I could recruit people. I was serving the Kool-Aid just like everybody else. This is great, come work with us. But then, what hours am I giving you? And they recognized that they wanted to work, they wanted to earn money, they wanted to give into the community. And so when we first set up our very first nursing pool client, Tammy went and did it, and they ran her butt ragged. And so we had to give her a break, like days in between, because they were up the stairs and down the stairs and passing meds and checking people. And she went from working one person in one person's home to doing, I think, 20 checking in overnight. So there was a little pushback there. She said, I just need some days. And it was okay. And we went back and we did it again. And it was easier to get other people to want to do it when we said, hey, you're our team. And no matter what happens in that facility, you come to me and I'm gonna take care of you. I'm gonna meet with their admin staff or their nursing staff if there's an issue, and we're gonna resolve it. And that actually did happen to us. We had sent one of the other caregivers out to a facility to do some overnight staffing, and the nurse was horrible to our member owner, was horrible to her. And we went back and we talked to the nurse on staff and we said, we're not having it. You know, the nurse got our caregiver injured by not providing the PPE that we required in our contract. Our contract also says that your industrial insurance will cover our caregiver if they're injured in your facility. And so state industrial insurance on the facility's dime paid for physical therapy for our person. But we stepped up and said, no, you take care of our team. We loan them to you, you be nice to them, you take care of them, you treat them well, or you don't have them. And yeah, I'm a kind of a hard person about that. My team is taken care of all of the time, or I'll pull them. And home care, facility care, whatever, if you're not respecting our people as they're serving you, then we take them back. And we don't come back. So that's the power to me in Cooperative, because I work for so many corporate pockets that said, no, go and work yourself to death for my money. And we will never, ever, ever sacrifice our people for money.
And your story also brings up an important point. I think sometimes when we talk about cooperatives, we romance them. You know, like it's a fairy tale, you're gonna be respected, all these things are gonna happen. But at the end of the day, this is hard work. And so what we're saying is that you're gonna work hard. You're probably gonna work harder than you did at the other job. But the difference is you'll benefit more. And this will be something that you have ownership in and you have decision-making power in. So I think we need to continue to stress that this is hard work. Yes. So whether you're going to be in a facility or someone's home, we won't take away the hard work. We will increase the benefits of that hard work and the return of that hard work. But it's hard work, right?
And we incentivize our work. We incentivize our work every way that we can. Whether it's financially, emotionally, physically. I go out and work beside my caregivers. The training, right? All of the time. And you hire heart all of the time, and you train her. You don't need to train the rest. Sometimes you don't need to train them. Sometimes they come amazing. But hard work and incentivize it, love it, support it, uplift it, and hold it up. Your team is my team, outstanding. And I tell them all the time how outstanding they are and how much I appreciate them.
We appreciate you.
We appreciate you.
Now we have a few more minutes for questions. So we'd like to open it up to the audience. And I just want to say that I'm amazed, at so much modesty and humility. But, the fact that these women, use their experience, their lived experience, their tenacity to bring these services and make them successful, and also to make their co-ops more successful. And that success is keeping people working and meeting. And I want to say this work also meets your social and cultural needs. We heard the story of the hospice services being in your living room, right? So this work comes from the heart and being driven by your lived experiences brought the unique and innovation. So I just want to remind us that's what is the secret sauce. As the Mondragon says, it's the people power, and you're the people power in your co-ops. So I want to turn it over to the audience if you have any questions.
I have a question for Susie. Is your hospice care, is that just under the umbrella of all of your caregiving services? And if it is, in your marketing, do you list it separately?
So the hospice care is just a portion of what we offer. We offer IHS, like Diane does, and homemaker and companionship and private pay, PCA, the whole gamut. Wow, your question just went right over me.
marketing.
Yeah, if I'm at your website and I pull down your services, do I see a separate hospice
Yes.
listing? And do you call it hospice, do you call it end of life?
End of life care is what we call it. We do put hospice in there because people connect that. But the end of life care, I think, is more appropriate.
Okay, and do you have a end of life team? Maybe people in your co-op who have a passion for that? And do you try to, like, if you have a client that is end of life, do you move your end of life hospice caregivers to that team?
Yeah, so whenever a hospice person comes in, I usually take lead on it so that I can set it up and then set the family up. And then right now, in fact, we're gone and we have two on hospice, and we do have Renee back there, who is just an incredible caregiver, and she is currently working with a veteran that is in hospice. And so we kind of move people around, and if anybody has an interest, I'm right there. I wanna let them know how to do this. And at any time, I can come and sit with the person, train one-on-one. I think that's the best way to train. And really, especially when it comes to end of life, experience is going to be your best teacher, because everybody's different. Yes? Oh, did you have a question? Yes. I'm ready to show now. The auctioneer up here.
About the marketing. I do want to just say one thing about the marketing. We do community health workers, and it's hard to market both effectively. We started a partnership with the University of Houston for their team of graduate students that do marketing to help us figure out our marketing strategy, because it's complex, right? So I just want to say, if you're near a university, they've been great partners. They've been working with us to figure out how to market our unique services. So that's just a plug for university partnerships.
One thing I did want to mention,
I think she has a
My name is Adriana, whatever you mentioned about the dolphin moved my heart. I was working at a city, and I was training a CNA, and the first day that she was alone, she was dealing with a death, and she cried in the middle of the hallway, and I had to assist her and just do whatever I had to do with this person, and I sent her to the bathroom to pray for her. I think you are the doulas of the home care cooperatives, and thank you for sharing the strength. But I wonder, for new cooperatives like mine,
It's okay. We'll wait for you. We'll wait for you.
We'll wait all day.
We'll wait for you.
You
Take your
lovely
time.
lady, you.
when you are at the lowest point that you don't have too much money to survive, and you have to choose to continue or have a big thought, what do you suggest?
Crying with you.
I think one of the
sorry.
biggest and
No
most,
apology necessary. We all have been where you are. And some of us still are, trust me.
yeah. There's people in here at this moment that are having really tough times. And one of the things, we all have just these huge hearts. We want to help everybody. And as far as cooperatives go, there have been, and I got tears in my eyes right now. And Dave can attest to this, that I have had many days where I just completely bawled because I didn't know how to navigate this thing. I didn't know what to do. I didn't know how it was gonna play out, right? And the one thing that I kept telling myself is I am in a marathon, I'm not in a sprint. I am in a marathon, I am not in a sprint. And the best thing you can do is reach out exactly like you did. And I will personally mentor you. I will personally mentor you. This is not easy work. We all are coming here and, you know, that's how, you know, you gotta be a little crazy to be in this, you know? But, yeah, I'll be a dolphin for you any day, and I'll pull all the dolphins I need to.
I think to the conference. So we practice nonviolent communication, right? If anybody's heard of NVC, compassionate communication. And one of the most strongest principles is making space for grief, right? We mourn. We mourn the hits. We mourn the loss of a contract, the loss of a client. We mourn the loss of a caregiver. There is so much emphasis on celebration and achievement that we don't have the full range of all the emotions, right? And so making space in your agenda with your team to mourn, right? We do rose, thorn, blossom. Because it's a full range of emotions. What is the thing you're excited about? What's your thorn? Right? We got a client right now that wants to meet in the middle of this conference. And I'm like, Dean, I don't want a meeting like Osada. We got to, right? They're a thorn to me, right? But what is my blossom being here, right? So I just want to say as a team, as human beings, we need to have a full range of emotion. And grief should be a part of our collective work. Because there's a lot to mourn, right? And to not recognize the mourn is not recognize my pain, is not to fully embrace my life and who I am. Yes. So as people who've historically been marginalized, you know, who are immigrants, who English is their second language, who was enslaved and built this country, all of that, right? So I just want to say, I think we need a caucus for people who have been historically marginalized, because our experiences are drastically different from everybody else. Even though we come and we make community, right? We're being hit in a way nobody else is being hit. And so we have to make space for that. And I just want to say, I encourage us to increase our ability to mourn collectively together so that we can move on and we don't have to feel so alone in our pain. Because we hold our pain individually, but we celebrate collectively. And that's not fair. For your amazing stories, your amazing tenacity, and your amazing innovation. Thank you.
Every time during this conference, I go back to my room or I go sit in the corner and I cry my eyes out. There's so many really empowering and great moments that happen here, and now I'm tearing up right now too. So we're about to go into our first break, but I have a few announcements. Our 11 o'clock sessions are concurrent